Hi everybody, I'm Dr. Pam DeWilde, so I am your medical director in West Virginia. I'm happy to be here with you today. So we have our lovely patient Ava, who's we're gonna pretend that she's a sweet little old lady supine in the nursing home. And we're gonna talk a little bit about how we would address certain respiratory illness. So this kind of work is good for any of your patients who have recently come out of the hospital with a pneumonia, somebody that the nurses are suspecting or might be developing a pneumonia, or COPDers, anybody with any kind of respiratory illness, even active colds and things of that nature. So one of the first things you're going to do is assess your patient appropriately, right? You're going to listen to lung sounds if it's appropriate because it's a respiratory patient. You're going to also osteopathically observe the patient. So every one of these patients is going to have a different rib functional pattern, right? Some of them have congenital malformations that are contributing to dysfunction of the rib cage. Some of them have rib cage changes secondary to COPD or chronic respiratory illness. So first observe that and make sure that you're documenting that within your physical exam. Sometimes when patients are more chronic, you're going to find that they have an odd relationship between the sternum and the rib cage. You'll find that the appropriate expansion is not occurring, or that the sternum is sinking in when they're taking a deep breath. All of those things are helping you to formulate an action plan for how you're going to address that rib dysfunction. And remember this, even though we're talking about very specific techniques that are addressing the rib cage itself, you are actively engaging with the lung tissue when you're creating proper function in the rib cage and creating change there. So in that observation, I also want you to pay attention to the fact that the patient may or may not breathe well into the lower parts of their lungs, right? There's large amounts of ventilation that occurs in the lower lungs. What is their positioning in the bed, right? Are they one of those mom-moms that's slumped down and they're closing off the lower lung fields? Then they're not going to get good ventilation. So first thing, make sure that they're in a good position. Make sure that if you have to, you talk to nursing about changing that positioning regularly, or making sure that nursing is checking in to make sure they're not sinking down into their bed. Then you're going to also observe the abdomen. So first things first, I typically will tell my patient that I'm going to be putting my hands along their rib cage, and that part of that means, especially for the females, that I'll need to be getting underneath breast tissue. Just be blunt about this, right? Patients do well with you stating that you need to get to their ribs, that you're talking about the anatomy, and that you as a physician need to access this space. If you have somebody that has pendulous breasts or you have a hard time getting to that area, simply ask that sweet little mama, hey, I need to get to your rib cage. Would you mind holding up your breast tissue so I can get to those ribs? This is especially important for you to just kind of practice if you're one of those shy people that's not really comfortable with that. As a female, I just kind of get in there, but you want to make sure you're communicating with your patient. So I tend to do this standing over the patient. I do my initial observation, as I've mentioned, and then I put my hands on the rib cage. I like to sink my hands softly into the ribs, right? A lot of these patients have previous falls. They're very sensitive to touch. When you put your hands on somebody's ribs, make sure that you're blending your hands into the tissues. You're not just grabbing them. You're definitely not using pokey fingers. So gently put your entire hand over the rib cage and then gently just assess the motion of the breath. Just from doing this, I can feel that she has a rib out on the right side that's anterior sublux. So right there, you already have something to write in your osteopathic structural exam in addition to your observation. Then I'm going to gently push laterally on each side into that rib cage. And what I'm feeling for is simple restriction, right? So if you've got beautiful motion and flow of the rib cage, when you push into that, you shouldn't feel resistance. Because of this anterior subluxation, when I push very gently into those ribs, I hit a brick wall, right? So that gives me more information. So that's where I would be directing most of my treatment. If you feel the need to, you can put your hands on the top of the chest wall. I especially like to do this directly from the sternum because you can assess so much from that area. So I'm going to gently put my hand here on your chest, and the same thing, sink your palm into the chest and feel for changes. So as I do that, I feel more that she's pulling into that right side because she's got restriction there, so she's having to work a little bit harder. Is that the sternum should float like a boat. right? So it shouldn't move like this all the time, but when you engage with it, it has the ability to move in all of those planes of motion. So what you're sensing for is the boat stuck in one direction? And are the contributing ribs anterior, posterior, subluxed as well? So let's get into a little bit of treatment here. So I'm going to take my hands on the patient and I'm going to gently engage by standing over the patient and gently leaning in with my body. When you're doing this to 15 to 30 patients a day, if you're doing everything from your elbows down, you're going to be incredibly sore. So lean into the patient, utilizing your back, and then engage with the tissues. So in order to fix this side, one of the simple ways to do that is that you simply create a fulcrum. So I'm going to rotate her rib cage. I'm going to test both ways. I'm more of a direct girl, and just because it's direct doesn't mean it's hard, right? So you're going to softly engage that direct barrier and then have the patient breathe. So all I've done is rotation. You can do rotation, side bending, etc., to create a point that feels like a fulcrum, where everything's hard under my hand. And then I'm going to have the patient breathe. So take a few deep breaths for me. As the tissues move, you move with the tissues to maintain tension in that space. Good. And then you slowly release and you recheck. So she's already moving very well, but this rib is still being fussy. We haven't quite done enough to get that to go. So in order to do this technique, so this is something that I developed because I see a lot of patients in the hospital. And these patients are very often unable to move, often unable to engage in many ways. It can be done two different ways. It can be done just with pressure and passively, or it can be done as a very gentle muscle energy technique. So I'm gonna take my hand, right? I'm gonna blend into the tissues. Forgive me for this. I'm not just pushing, right? She's not a bouncy ball. I'm gonna put my hands in and I'm gonna blend so that I feel like I've lost the surface of my hand in the tissues. I'm just supporting the shoulder. It's not really doing anything. It's just supportive. And I'm pushing deeply into the bucket handle ribs. Now, I say deeply, but meet the tissues. If you push and you're getting a wall pushing back at you, don't shove past that. We're not chiropractors, okay? So you're gonna gently push into the tissues and you're gonna hold and allow the patient to breathe. So this is option one, the more passive option. If you have a patient that can engage at all, I would encourage you to tell the patient, push your ribs into my hand. So push your ribs into my hand. Nobody ever gets that wrong. Don't make up other words to describe it. Good, take a deep breath and let that go, right? So similar, just the same old muscle energy techniques, 3 to 5 seconds of holding that contraction. Think about all the muscles that are attached to those ribs. Every one of those is engaging in order to create this motion, and all of those things are responsible for helping the function of the rib cage during respiration. So you're gonna do this a few times, just like any other muscle energy technique. I'm gonna push, now you push. Good, 3 to 5 seconds, take a deep breath and relax your whole body. And I'm gonna push into you a little further. So I'm a bouncer. I just do that, not like a bouncer, but I bounce, right? So I'm going to bounce the ribs slightly because I want to feel that mobility. It almost blends in articulatory with the muscle energy that you're doing. So I do a gentle bounce to engage that barrier further, and then one more time, go ahead and push. Good. So every time she does this, she engages the muscles a little bit more because we've increased motion in that space. Good. Now, that's a simple technique. I would encourage you to do it on both sides. If you have students with you or another resident or another colleague and you're doing this at the same time, never do it at the same time, right? You can alternate. One of you can do one on each side, but you don't want to decrease ventilation in the lower lung fields at the same time. That would be bad. Now, let's say that rib is still not totally moving. That technique is excellent for making most rib dysfunctions, whether it's a subluxation anterior, posterior, a torsion, whatever it may be. Usually it'll fix with that. But if it doesn't, then you can simply engage with a little BLT. So I usually will bring the patient's arm to their side. I'll put it on their chest to get it out of the way. I'm going to take my hand and I'm going to scoop it under the patient's body, find the spinous process, fall out to the costotransverse junction, and make sure that you're engaging with the rib itself. So you're going to find the rib that's the problem. Right there she is. She's bouncing, she's moving better, but it's still there. And remember, this is quite painful for a lot of people, so I want you to gently slide. If you're having trouble sliding underneath the patient, One little pearl is to flip your gloves inside out. They become way more slippery. With the front hand on the anterior side of the surface, I'm going to engage with that same rib, and then I'm going to create a sandwich motion. So essentially, I've got the rib on both sides. I'm going to gently sandwich the rib, and I'm going to pull it toward myself. In doing that, it's going to disengage, and you're going to feel motion. And if you're like, I don't feel motion, this is not a thing I feel, then just hang in there. Allow the patient to breathe several times, and the breath will do the work. Good. Take a few deep breaths for me. I'm just maintaining that pressure and creating a fulcrum for the patient to breathe around. One more. Good. And then because I like to bounce, I'm going to give her a little bounce, just for a little give. Good. So that rib is already doing much better than it was before. I never want to leave a patient with respiratory issues without doing something for the diaphragm. Now, doming of the diaphragm can be quite painful, so that's not the thing I'm going to teach you. There's two different ways to go about this. You can engage with the diaphragm unilaterally, or you can do so through the patient, or if they're a vibrant, go-getter type of patient, then go ahead and do the traditional doming of the diaphragm. The one that I'm first going to show you is through the diaphragm. So you're going to engage the patient this way. I'm going to have my hand along the diaphragm in the back, and then my other hand anteriorly. I'm going to do this unilaterally. Think about the diaphragm attachments and engage with that musculature. So I'm going to sink my hands. I'm sandwiching my hands in a BLT motion just like I was with the other ribs, except that I'm putting my attention on the muscle and feeling for relief or release. Both, hopefully. As she breathes against that, you can feel a tightening, especially posteriorly, as the diaphragm tries to push against me while I'm creating that tension. And it kind of creates a passive muscle energy. Good. So I would allow her to breathe a few times until I sensed change within the diaphragm. The other way is this way, if you're doing it unilaterally. You're going to find the lower edge of the ribs, and rather than deeply getting into that space, I want your fingers to just simply fall off into this edge. You can kind of position yourself a little bit closer to the head of the bed so that you can get at that diaphragm from this position. You're going to use the pads of your fingers. You are not digging into the abdomen. That's a great way to not make friends. And you're going to gently engage with the muscular edge of the ribs here. You're putting more attention here because of this attachment. And you're just going to hold that while the patient breathes. If the patient doesn't tolerate this or they're incredibly ticklish, then just don't, right? Do it a different way. Or you can do a gentle form of doming. Good. Now, with anything respiratory, especially if they have a lot of accessory muscle usage, right, you've already addressed the diaphragm, you may need to also put a lot of attention into the scalene attachments and making sure that you're treating the cervicals and the upper thoracics as well. But after you've done this kind of work for their respiratory, to improve respiratory function, make sure that the work is not done if they have an abdomen that's full of poop, right? So you need to make sure that you treat the abdomen accordingly so that they can get a nice deep full breath and increase ventilation in those lower lung fields.